Oh my God, thank God for that. So I'm going to wait for it to come up because it does usually take like a minute, doesn't it?
Oh, it's up. I can see it's up.
I can't see it. That's not fair. But it'll be there in a sec.
Oh, hold on.
Oh, and then we have to take the volume off, don't we?
Yeah, there we go. I fixed that.
Oh, look, I can see us. Okay, okay,
and we can see comments. Yay. Oh my goodness.
All right.
What a stress.
I've started recording, but anyway, we're good to go. So hopefully people will show up, even though like we're like 10 minutes too late. Okay. All right. You know what's really weird before I just start talking and before people jump on is the delay. I got to look at the Zoom, don't I? So people are going to start coming on. So I am going to introduce you guys. Okay, we'll do a little countdown. 3, 2, 1. Hi, menopausing so hard gang. Welcome to this live webinar with two legends of the PT world. I am very excited to have both Marika Hart and Antony with us today to talk about all things pelvic health and menopause. So I'm going to do a little intro of you guys, if you would let me. So Marika, pelvic health physio, postgraduate certification in clinical physiotherapy, specializing in continence and women's health. Spending years teaching pre and postnatal exercise classes to hundreds of women. And a little fun fact about you, which I found out the other day, which is pretty amazing, is you're the Taekwondo Queen.
I do dabble in martial arts. Yes, it's true.
She doesn't just dabble. I'm a black belt in karate, but like that's it. That's a first dan. I haven't done it for years, but she is a 2 times world champion in the advanced senior division, and Australia's most achieved athlete on the global scene in the last decade, despite it being your first appearance. Is that right? That's insane.
Oh gosh, it's going to make me blush. Yes, we had a World Cup here in 2019 in Sydney, which I competed at, and it was great. It was terrifying, but it was really fun. Yeah, well, it was good.
That's amazing. And then Antony, you may know him. People like already knew you two guys, though you were well established, obviously, but is known as the physio detective and owner of My PT Education. And I was going to say, for anybody listening who is a coach, he does some amazing educational courses. I think the one that would probably be the most relevant is the female athlete course. So I'm going to give you all of the information to where you can find them both, but one of the best resources that they have, which I personally like, is their podcast, which is the Women's Health Podcast, which they host together, and they interview leading authorities. And yes, I was on.
That's why we had you on.
And they answer questions and share their thoughts to provide the general public with the best quality information that they can find on all aspects of women's health. And just before we get started, I just want to say a couple of things. First of all, I am going to be the facilitator today. We've already got all of the questions. We're going to go into these questions. Antony and Marika have this all covered. I will maybe chirp in a little bit. But before I hand it over to them, I just want to reiterate that any information they give you is not intended to be a substitute for professional medical advice, diagnosis, or treatment. So before we start, welcome and thank you so much for doing this. I very much appreciate you doing this for the group.
Thank you. Thank you for having us here. And it's always fun to do things with the both of you. I think you're both amazing women, and always feel privileged to be able to have chats with people like yourself, Amanda. And I learn every time I talk to Marika. I learn from Marika.
We like to just chat, don't we, Antony? We can talk for hours, but it's really funny being on the other side now. Amanda, I like to be the person just asking other people questions and picking their brains. So, you know, I feel like I'm a bit in the hot seat today. It's a different experience.
Oh, you know what? I didn't do my crikey. I didn't do it in my Australian accent. I meant to say, so these guys are all the way over from Australia. They had to get up super early to do this. So thank you for that. So when I polled both my subscriber list and the group, I got so many questions back. I mean, so many that I know we can't answer them all. So they've been categorized, and we've got some high level topics to discuss, and they're going to try and touch on everything that you spoke about. So I'm going to hand the floor over to you guys. I bet you've got like this double act that you do, like one goes and then the other. I don't know. So I'd like to just hand it over to you and ask you if you could please start with something that actually happened to me, and that was pelvic floor dysfunction, where it was hypertonic, like tight, rather than like needing to do more strengthening, and other issues that impact the general health of the pelvic floor, if you would please.
Shall I kick off, Antony, and then jump in?
Yeah, well, I was thinking what might be helpful to kick off with is what we both do and how we are similar and different, so that people understand the perspectives that we bring.
Sure.
You know what? That's so great. You can tell you've done this before. I'm just like, he's so good.
Go ahead, Antony. Tell people what you do.
Okay. So I do work at the junction of ortho PT, sports, like not just injuries, but sports performance, and as well as helping people with pelvic health issues such as incontinence, prolapse, pain, diastasis, if you want to include that too. But I don't do any internal examination, so I need to work closely with pelvic health therapists that work internally. And so, yeah, not being able to do an internal examination means that my skills tend to be not internally based, which suits lots of trainers. So yeah, that's the fun part that I have there. So I go from the highest level athletes down to the bare amateurs, and from young people all the way through to the elderly. So that's how I work. How do you work, Marika?
Well, I work in public and private. I work with obstetric and a lot of urogynae work as well. So it's, yeah, I like Antony, I came from very much a musc and sports background, and then transitioned into pelvic health because I had babies, and then went, shit, I don't know anything about any of this, and I need to learn this. I love your question, Amanda, about overactive pelvic floors, hypertonic. You'll hear a lot of these terms thrown around. So I just wanted to quickly throw in some of the more common symptoms that people will complain about if they have those issues. And this will be things like pain with sex is really common. So some women will have what we call like a primary dyspareunia. So they've never been able to have sex without pain. And then other women might have a secondary. So it develops later, maybe after childbirth, maybe after menopause. So painful sex is a really common symptom of an overactive pelvic floor. Difficulty emptying the bladder and bowel. So they might sit down to do a wee and it's actually really hard to get started, or it's a really slow stream. They might have constipation, difficulty emptying the bowels. So just never really feeling like it's easy or it's fully complete. So they're really common symptoms. And some women will have a lot of urgency and frequency. So they just need to pee all the time. And sometimes it's not that they have a UTI or anything like that. It's just that they have this overactive pelvic floor. And so those are just really common symptoms that people might experience. So I think when it comes to pelvic floor, especially in the postnatal period or in the perimenopausal period, everyone's always thinking, oh, I've got to get stronger, This thing is weak. If they're leaking, it's because it's weak. If it's pain, it's because it's weak. And so we can kind of fall into this trap of doing what I know the Americans call Kegels. We don't call them that here. We just call them pelvic floor strengthening. But people really fall into that trap of I must do more because that'll make it better. And as Antony says, more is not better or something like that.
Harder is not better.
Harder is not always better.
Harder is not always better. And in fact, like the Kegel message is, many of us over here, and I'm not a specialist, I have done some training in pelvic health, but just the message that a lot of women get from their doctors is go home and do some Kegels and hold it as tight as you can for as long as you can. And all of the symptoms that you explained is something that I've experienced, like the painful sex, not being able to finish going to the toilet, and sometimes just dribbling and not being able to like actually contract properly. And so what does it mean to be hypertonic although it came up in, it's really funny, it came up in the closed captions as hypersonic, which I actually quite like.
Oh.
Yeah, so
I'd like a hypersonic pelvic floor. That sounds kind of cool.
So what does it mean to have a hypertonic pelvic floor?
Do you want to jump in there, Antony?
Hypertonic is a funny word, isn't it?
Yeah. We call that a handball in Australian rules, because I just went, oh, tricky question, boof, over to Antony.
I think we prefer the term overactive pelvic floor because it describes most people. Hypertonic can have a medical assumption that there's a neurological reason why. And so hypertonicity is different to, say, an overactivity. And the overactivity can be behaviorally driven, or it can be secondarily occurring because of other things, like, you've got other things going on in your life. And so your reaction to things physically may lead to your pelvic floor being more active. So that's like a secondary effect of having an overactive pelvic floor. Or you may have a history of trauma, and it may be a primary type of, my pelvic floor does this because of a history of trauma. And that trauma can be, obviously abuse, but also birth trauma is another common one for the pelvic floor. It could be an accident. So, car accidents, bike accidents, many different types of accidents can occur that lead to your primary reaction or a secondary effect of your pelvic floor being more active, but also the behavioral aspect as well. So, somebody's told you that you have to do your Kegels or your pelvic floor exercises, or you're leaking and you think, well, I'm leaking, therefore I need to do more. And like we said, harder is not better. So it gets frustrating because you're leaking more, you're trying harder, and it's not solving the problem. So most people just take it on themselves and say, well, I'm obviously not good enough. I'm not doing it enough. I'm not doing it right. Whereas it might be actually more helpful to think of it as maybe the diagnosis is wrong, or maybe the advice isn't the most helpful. Maybe we as providers have to get our act together and make sure that we go through and not just give generic advice, which is why individual assessment is so important.
So I think that's the next question. What do you do and how do you know? Because we hear generalized advice all the time, and people over here are selling all sorts of like gadgets to stick up you, and you've seen it all, I'm sure. And so like if somebody's having some type of dysfunction and they actually don't, I assumed mine was weak. Like I went for a run once and peed myself and was like, oh, like I have a weak pelvic floor. Like nearly a year later, went to a pelvic health physiotherapist, and she said, your glutes are like locked on and your anus is like as tight as I've ever seen it. And I'm like, oh, lovely. But it was good because it helped.
So she called you a tight ass?
It's not the first time. But yes, I was a tight ass. But that was like a bit of an epiphany to me. I was like, oh, so that's a thing. And I think most women, like you say, have the assumption it's a weakness. So what do they need to do? How do they determine what the dysfunction is? How does that happen?
I just want to jump back on something Antony said, which I think was really important about, and I will answer your question, Amanda, I'm not dodging it. About the protection side of things and the trauma and the stress and anxiety, etc. But we are, as women, completely wired to protect that area. Okay, so when we have fear, we have stress, we actually subconsciously contract our pelvic floor. And there's been really cool research where they actually put a little electrodes like on upper trapezius and then put little internal vaginal electrodes and had women watch like a scary movie, and not like a sexually driven scary movie, just like, something where things jump out. And you could probably guess this, but what do you reckon is the first muscle that switches on? The pelvic floor. Yeah. So we are absolutely hardwired to protect that area. So for a lot of women, and it's completely subconscious. And this is something that one of the things that we have to work with a lot of women is, like Antony talked about, all those other things that can influence the pelvic floor. You can't just tell a pelvic floor to chill out and to say, oh, just relax and let it go. And, you know, working in the public system, you know, it's really eye-opening for me, because I do see a lot of women with a long history of trauma and sexual abuse. They've, like Antony said, they might have had or PTSD from birth trauma. They might be going through this, you know, huge stress in their life. They've lost their job. I mean, COVID, let's talk COVID, what that's meant for people, looking after ill family, losing jobs. All of these things which ramp up that sympathetic nervous system can absolutely impact on pelvic floor as well. So we have to really think outside of the vagina. And we don't want to narrow in. And I think that's, I guess, where Antony and I come from, because we came from that musculoskeletal pain background, is that we try not to just think it's all about these little muscles internally. But having said that, like if you wanted to assess a pelvic floor and determine whether or not this is a problem, it's a little bit subjective, because we don't have cutoffs to say, okay, well, if we put for instance, a probe in and use a machine that measures things, what would be considered overactive? What would be considered normal? What would be considered low tone and underactive? And it's a bit subjective, right? Because I work with some athletes and they have a higher tone pelvic floor and they don't have any problems, okay? And I'm not going to get them stretching and letting things go if that's not a problem for them. So if I palpate, they've got high tone, they're emptying their bladder and bowel fine, they're exercising, they're not leaking, they don't have significant tenderness, they're not having painful sex, I'm actually just not going to mess around with that. Versus someone who actually, you know, they can't have sex. You know, I see some women who you cannot even put the tip of a finger into the vagina because it's such high tone and it's a dysfunctional thing for them. They can't have sex. They want to, like, I get women referred from a fertility clinic because they can't get pregnant, and they can't get pregnant because they haven't been able to have any kind of intercourse. So we have to kind of put it all into the perspective of what is this person's problems and can they do all the things that they need to be able to do, rather than, I think, it being an arbitrary, you know, strength or tone thing on a measure. Does that make sense? You're muted, by the way.
I know, I was pressing buttons. Stop putting pressure on me. So essentially, think outside the box. I got that one. I like your little joke there. That's awesome. Okay, good. So, and then you can only have that by an assessment. I get that, right? Like, I mean, I'm trying to encourage all women to try to get their doctor to refer them to get to a pelvic health physio, because I just don't think you can beat it. I actually believe that everyone should just get one for free. So when we move into menopause, those issues can be exacerbated by some hormonal fluctuations. And I know we're going to get to that as well. So can we just move on, or unless you want to stay on that one, Antony, and just take that into like the urinary things that we see because of the pelvic floor dysfunction?
Yeah, I'm happy to do that. I think in terms of assessing it to determine, obviously the individual assessment is the best way to go. The way I think of it is that the more we know about problems, the more that they may possibly create concerns, fear, anxiety, and people, you never look at somebody saying, oh, you look more relaxed and you're telling me that you're more worried. Like, we don't ever say that. And that pelvic floor reaction, whether it's from a movie, whether it's because of a sharp breath in, whatever it is, it responds to pressure. That's how the pelvic floor, I think, works automatically, is reacting to pressure. And so anytime you increase your muscular activity, you increase that pressure. So both Marika and I, we definitely look at those things going on in people's lives: stress, anxiety, depression, pain-related concerns, fear avoidance behaviors, injustice experience will generate a lot of that stuff too. Even shame, self-compassion, sensitization issues where the brain actually changes. All of these things we look at as part of what's going on. And so you'll see symptoms of it. For example, with the urinary stuff, leaking, so leaking on a run. You know, so the question that I always like to know is, when is it happening on your run? Is it the first few steps? Is it a certain distance? Is it a certain time? Is it a certain route or route, depending on who's listening? So You know, are you losing all of your bladder, or are you losing some of your bladder? And sometimes, like if we think of leaking as, and Marika will correct me if I'm wrong, and you can correct me if I'm wrong, Amanda, you know, there is this pressure that you have inside your bladder, and there is a pressure that your sphincter, assisted by the pelvic floor, can hold the urine in, okay? And so if that pressure in the bladder increases more than the squeezing pressure of, if I squeeze more up here in the bladder than the sphincter can squeeze here, then you will get leaking. And one of the easiest ways to increase the pressure in the bladder is to increase your abdominal pressure, intra-abdominal pressure. There are other conditions where the bladder will squeeze more. However, that's the most common one. And so if that pressure increases, it may just go past that threshold. You add fatigue in there, you'll get a little bit of leaking. That's different to somebody just losing their whole bladder. Like I'm thinking of different things there. So that's one way to assess. If I'm hearing lots of little drops, I'm thinking a pressure issue, not necessarily a weakness issue, maybe an endurance issue, but nobody is running thinking, hold your pelvic floor, because that's just not normal.
Lots of people do though, Antony. And
I know, it's not normal. Please stop. Because they do it because they're told to, right? Like that's,
so
hold
that's
your
a
pelvic floor when you run.
So that's a really good point. Like, so urinary leakage in menopause it seems to be one of the big problems that a lot of women have, and they don't report it. They just get on with it because that's sort of the way we've been conditioned, and it's also embarrassing and etc. Right? I understand all of that, and they've basically just been putting up with it, or then, like you said, they're like thinking, I'll go for a run. What do I do to stop myself leaking? And what is considered normal? Like, so as we go through menopause and we start aging, what should we expect our pelvic floor to be able to do? I mean, there's going to be some atrophy that happens naturally with aging and menopause. Like, what can we expect and what should we put up with, essentially?
What a great question. What should you expect? Well, we know there's a massive drop in estrogen, right? Through that perimenopausal, and definitely at that. I hate the way that people think about it. It's like it's this cliff that you drop off, and it's just like, you know, everything happens one day and then it all just goes to shit. And we know that this perimenopausal period can last for quite a few years, and there's changes over that time. But, you know, one of the most obvious things is this drop in estrogen, which affects the tissues around the urethra and affects the tissues around the vagina. So what is common, and I'm not going to say put up with, because I wouldn't want to put up with any of it, and I'm not far off, and I'm heading that way, so believe me, I'll have conversations with you in the future, Amanda. But we, you know, so it is relatively common for some women to experience leakage. Okay, maybe some increased urgency and frequency of urination. Maybe the bowels start acting up a little bit, and that could be towards constipation, or it could be the other way with some of these hormonal changes. A lot of women experience dryness and pain with sex. So these are all common things, but for a lot of it, there can be things that can be done about that. And so I know you sort of asked a question about vaginal estrogen and whether or not I'm happy to talk about it. Well, I am happy to talk about it because we use it a lot in clinical practice. So I'm really fortunate where I work in a women's hospital is that a lot of the patients I get referred from the urogyne team or the gynae team. And I'm so blessed because they come to me with I have all their medical records. I've seen all that the medical management has been done, all the urodynamics, if they've been done. I know the medical side of things is managed really well, which is much harder privately to try and get all that information. But the medical management is really important. This is a multidisciplinary approach. You know, like Antony and I are not gods. You know, we help a lot of people, but it's part of a team. Okay. So vaginal estrogen, which here in Australia is often can be prescribed by a GP, or it can be prescribed by a specialist. And we use two types. One is the Vest and one is Vagifem. And typically people will use it every day for a couple of weeks and then 2 or 3 times a week ongoing. In my experience, a lot of women do very well with vaginal estrogen topically. So that's basically a little cream or a pessary that they actually insert into the vagina, and it gets absorbed locally through the tissues. Now, of course, there's that question about whether people have had cancer, whether or not they can have it, because often they're not allowed to have systemic hormonal therapy. but that is always something that they would have a conversation with their oncologist about. But for a lot of doctors, the topical stuff doesn't seem to have the effect, but I'm not a specialist, so don't quote me on that. But, you know, I can tell you, Matt, I've had some women who've come to me. By the time they've come to me, they've started on their estrogen, and the doctors have sent this letter saying they're urinating 12 to 14 times a day, up 3 or 4 times a night, can't have sex, it's disrupting their life. By the time they've come to see me in the physio department, because it might be 6 weeks or longer, their symptoms are gone. And they're like, oh no, dear, I'm absolutely fine. Everything is fine. I feel great. And I think, shit, we need to make sure this is an option for women, because it really can make a difference. And the reason that it helps is that in the urethra itself, we've got a muscular layer, but inside that, we've got this sort of vascular plexus, which actually helps close the urethra. So it helps plump that up. So if you think about it, the tube is not as open, basically. So it helps women control their wheeze. And then putting it through, you get a lot of vaginal atrophy with perimenopause and menopause. And so it actually helps, again, make the vaginal walls more vascular, more moist. And so a lot of women, a lot of that sensitivity goes away. And that sensitivity of the tissues can, again, drive that needing to pee all the bloody time. And some of that can just go away. So was that the question? Have I just gone off on a random tangent?
Well, you have, but you've answered everything I was going to ask you, which is awesome. And it was like, there's a lot of women get up and have, you know, frequent urinations during the night, and they're already struggling with insomnia. And then this comes along and they've got night sweats. It's like their sleep patterns are messed up. But I also think that might tie in to what Antony said about, you know, like the subconscious, or well, you both said about the subconscious side of the way the pelvic floor works as well. Because if one thing's knocked out of kilter, then it's going to sort of have this snowball effect, right? But the so yeah, the localized estrogen is typically the thing that I hear from women that they try, and it fixes their problems, right? Because I spoke to a gynecologist once, and she said, imagine like a jam donut and all of the jam's being squeezed out, and then you give estrogen and it literally pumps it back up again. And
I like that. I'm gonna use that.
You want your vagina to be a jam donut every time. Okay. Okay. Is there anything else on the urinary side before we move from pee to poo, if you like?
I mean, I guess key things will always be, you know, fluid intake is really important. And as you know, we're having a chat about this before. Fluid loading in the afternoon, I see quite a lot. So we do. Oh, what happened? Nothing.
Just carry on. Pretend I didn't do that.
I'm seeing some funny faces from Amanda. Sometimes what we see is inappropriate fluid intake, potentially, or fluid intake that's heavy at the end of the day. So some of my clients, when they come in and I do a bladder diary, so we, as pelvic health physios, we'll do a pretty comprehensive bladder diary with anyone who has urgency and frequency and urge incontinence and things like that. And you'll see there's like nothing. Oh shit, I haven't drunk anything today, and I'm supposed to drink 2 liters a day. And then they start drinking it at 5 o'clock, and then they're up all night peeing. So little things like that can make a difference. Or, you know, some things are bladder irritants, and they might not be a problem when you're younger, but maybe as we hit perimenopause, suddenly all the green tea starts to be an issue, or the fizzy drinks, or that sweeteners are a big bladder irritant as well. So it's just sometimes experimenting a little bit with that, because, you know,
I've had alcohol, Marika. Is alcohol part of that?
I'm in denial over that one.
Okay, all right, that's asking an Aussie to put down the beer.
Yeah, caffeine, tea, herbal teas, sugar, sweeteners, and fizzy drinks. They're probably the main ones. And now I'm going to shut up and let Antony say some stuff.
There is one more thing that we didn't get to talk about, which is like using devices for the urinary side of things. And whilst we have on the one hand, you know, people who are very, very overactive for all the different reasons that we've already described. You have people that are very underactive due to usually neural reasons. Sometimes there can be pelvic floor injury to the muscle itself. And so, you know, being able to talk about those devices, stimulating those devices. And again, or maybe not again, I say it a lot, how you do what you do matters more than what you do, right? And so the way that you do whatever activity or your pelvic floor muscle exercises makes a big difference. And so there are people that are very frustrated. They go to the physio, they go to the PT, and the PT says, you're doing the pelvic floor exercises correctly. Now, I don't know about you, but anytime somebody puts fingers inside anything, you tend to notice it, usually, right? And so that's a big biofeedback way of telling what's going on. And that's what these devices are as well. They can help you determine what's going on as best they can, but there's something inside and now you're reacting to that anyway. I've seen too many people, because I'm external only, I've seen too many people that see the pelvic floor physio, they're doing it correctly with the physio, but then when they go home, I think, this is just a suspicion, okay, there's no evidence. I think what they're doing is they're trying to recreate the feeling that they had with the physio, but because it's such a strong, intense, personal feeling, I think they start looking for some sort of feeling down there. And what they end up doing, or what I'm seeing, is that they're bearing down. And then they go to the physio, they've got the feeling there from the physio says, well, you're not bearing down. And so I encourage people to check externally as well as, you know, having pelvic floor physios teach them how to assess themselves internally as well, so that they can do that in the shower, clean hands, all the hygiene things. But yeah, I see too much of it as an external pelvic floor therapist of bearing down, and they're being told by the physio. I don't want to throw the physio under the bus. I honestly think it's because people are looking for that feeling, that feedback of, am I doing it right?
So talking about devices, you know where I'm going to go. So
you're going to talk about your special device that you put on Facebook the other week, Amanda?
It was an optical illusion. I had my hand really close to the screen like this. It looked ginormous. It looked ginormous. It is pretty big. Vibrators. Okay. Do they have a place in pelvic health, wellness, fitness, pelvic health, fitness?
I'm laughing because my son just walked in through the door just as you asked that question, but he was singing.
And he just walked out.
No, he was singing. He was oblivious. Are you talking about for self-pleasure? Are you talking about for releasing muscular tension?
Yes, I think I'm talking, of course, self-pleasure comes as like just a byproduct of it, but like, can you use them to sort of understand like any type of feedback, or to relax you, or even just to get the blood pumping? Like, does it help you in any of those respects?
One sec. That's a good question. I don't know that we know that. I mean, we use a lot of what we call vaginal trainers, which can help, which are basically dilators. So dilators are used quite a lot, which can help teach people how to relax with the sensation of insertion if there's pain with sex. We know that vibration's been used for decades in the neurophysio world, because it can really help with relaxing muscles. So it's like a down, you probably know a bit more about this, Antony, but it has an effect on the muscle spindle, doesn't it, which helps it relax. So I mean, vibration's been used for a long time with hypertonic, like actual like neurological conditions. So it could absolutely help. And I sort of think anything that encourages you to enjoy and see that area as being something that you can touch without pain, that you can explore and enjoy, basically, I think is a positive thing. So I'd say I probably don't, like, I recommend patients get them. We don't use them in the clinic. Like, I don't have vibrators in the clinic that I use internally, but we do use the dilators quite a lot as well. That probably didn't answer your question very well. I'm distracted by children going to school.
No, that was fine. That was fine. Yeah. Children don't need an education. They're fine. Okay. Sorry. Go for Antony.
I was just going to add something. I saw something the other day. I believe it was a study in inverted commas by a product developer who showed that using masturbation during your menstruation, during a period, helped people with their pain, with the cramps. So I'm going to go try look for more studies on it, but I did see it in passing. I think it was like a press release type thing. Generally speaking, I defer to a pelvic health physio to talk to them about these things. However, I do know that lots of people have said that it's been able to help them relax. And one of the topics that Marika and I really believe in talking about is that holistic approach and things to do with calming the nervous system down. So decreasing the sympathetic drive, increasing the parasympathetic drive. And so we know things like deep breathing, meditation, all of these things come into it. And also, you know, it's like an atom bomb dropped on your neural system when you have an orgasm. And that's why if a vibrator helps you to orgasm, it has that place as well in therapy. Because I see so many women, some people, they don't feel comfortable talking about it. I'm always prepared to talk about it, but I'm led by them as to what they would like to do. So I always offer a range of choices. Some people are like, I'm happy to talk to you about it. That's cool. We talk. And other people are like, yeah, no, I might go see somebody. Who do you recommend? And I give them a range of choices again. But I think it's important to realize that meaningful activity is really important. If you think, oh, I have to do this, like you're not getting the full benefit of the range of choices that you have. That's why, you know, whilst how you do what you choose is not as important as what you choose is important in terms of, do you actually want it? Do you like it? Do you enjoy the thing that you're doing? This could be sexual activity because we started with vibrators, but it could be exercise as well. It could be gardening. I don't like my dad, classic example. I don't like doing these squats. I said, okay, well then carry some rocks around in the garden. You know what I mean? Like he goes, okay, that's I'm going to do that more because I feel like that's like, I do have to move some rocks. So that is more important to him. And he's going to have a better effect on him than making him do squats and lunges, which he just hates. Like, I don't even bother because you're not going to get the benefit of the exercise. So yeah, anyway, I hope that was helpful.
I'm just thinking on a side note, because Amanda did ask about devices and stuff too, because we were chatting, Antony, before about things like muscle stim machines and biofeedbacks, because there's lots of things you can shove in a vagina. I'm not going to talk about jade eggs. Just going to leave that one out completely.
Just say don't.
But there are, what's that?
Just say don't, Gwyneth. Right? Yes. Just say don't do it.
Yeah. So we're not going to, you know, promote any goop stuff on Amanda's. Oh, she's not even there. I just mentioned Gwyneth Paltrow and goop and jade eggs, and we're just going to move on from that.
Yeah, let's not. My computer's just not charging and it looks like it's not going to survive, but it's fine. I'll make it work. If I disappear again from the screen, it's just because I'm trying to rescue my computer. So people were talking as well as about having rectal issues and prolapses. Can we sort of like expand into that topic?
Absolutely. Where do you want to start? Well, should we just start with like bowel function? Because I always think it's really, I'm gonna quickly talk about what's normal, because I spend half my day talking about poo, and because I think it affects everything. And anyone who's had small children will know that if you've got a kid who's constipated, it ruins everyone's lives, right? So constipation will cause pressure on the bladder, so people will leak more. It can cause more prolapse kind of type symptoms, that heaviness, dragging. So what's normal in terms of a poo is we want, like, in terms of the consistency, like a long uncracked sausage, I'll often say, which is a type 4 on the Bristol stool chart. That's ideal. What's normal in terms of frequency? It's anything from 3 times a day to 3 times a week. Now, what happens is that, like, guys, I joke, are like freaking trains. Like, they run at the same time every day. They're brilliant at pooing. Okay. And I say this to my clients and they laugh because it's so true. is a guy will get up in the morning, have his breakfast or cup of coffee, and then at 7:23 he's on the toilet, bang, done, move on with his life. We as women, we have these great hormones which can slow our gut transit, which means it can get drier, because the longer things are in our system for, the drier it gets. We get distracted because we've got 1,000,001 people wanting things from us, so we skip the urge. We might mess around with our diet quite a lot because, again, we're doing 1,000,001 things. So there's all these things that, and then the hormonal changes. So I think it's really important, where possible, for women to attend to the urge. So when you get an urge to poo, that moment, things have moved down into the rectum, you get that sensation, that stretch. At that point in time, your internal anal sphincter is relaxed, okay? So you can go to the toilet, relax, use your footstool, breathe, relax your external anal sphincter, and let it all come out. What happens is, after about 15 or 20 minutes, is that it closes shop. So our internal anal sphincter then shuts. So what we do as women is we go, oh God, I need to poo. Oh, I'm just going to make the lunches and do all these other things. I'll come back to that. Half an hour later, we go sit down and then nothing happens. So we have to then wait for that next mass movement through the gut, which can take 3 or 4 hours. And so we can really get stuck in these cycles of not listening to our urge, getting drier and harder poos. If you add some hormonal changes, some fluid decrease, effects of food, etc., as we can really get stuck in this cycle of constipation. And the reason I bring it up with rectal prolapse and Erector Seals is that constipation is a real problem, and it can cause a lot of pressure in the posterior vaginal wall and in the rectum. So we've got to sort out the bowels. So we're emptying regularly without straining, without bearing down, is really important. The other thing with what's called Erector Seal, which is actually where it's still a vaginal wall prolapse, but it's at the back of the vaginal wall where the rectum's just sort of dropped down, is that I don't know if people are watching this or listening to it, but there's you can end up with this little pouch basically, and the poo can kind of just get caught there. So for a lot of women, to help them empty is to actually just stick a finger or a thumb into the vagina and push against that back wall when they have a poo, and that helps them get that bit out. If they don't like to use their hand, then there are wands that you can use, and you actually just literally stick that in the vagina and push that against that posterior wall, and it helps get that little bit that's catching. So I think that's important to know about too, because when women can get that bit out, empty fulling without straining, a lot of their symptoms are improved.
You've just described exactly what it feels like. I did go through that type, and sometimes after having sex, it would make me go, and I think that's sort of maybe, I don't know if that's put enough pressure on it, who knows. But what I was going to ask you is, you mentioned about the stool, and I've seen those. Why are they helpful? What does it do to the body's position?
So our rectum at rest so we've got a muscle called puborectalis, which links around like that, and it creates a 90-degree angle. So for people that are watching, hopefully they can see that. And so that helps us maintain continence so we don't have accidents, in conjunction with our sphincter muscles as well. That puborectalis is really important. What happens when you use a stool is you lift your knees higher than your hips, is it actually straightens out the angle. It helps relax that puborectalis, and it makes the rectum straight. I'd recommend everyone on here to go and Google squatty potty on YouTube, or just go on YouTube and watch the squatty potty video, which is about a pooping unicorn. It is freaking hilarious. It's comedy gold. It's actually for a product, but it explains it really well.
I've just put the link in the Facebook group for people.
That's awesome. Thank you. I've always wondered about it, and I've seen it as a product, and I was like, hey, it's another gimmick, because I'm forever jaded, as you know. But okay, that's great to hear. Excellent.
Yeah, and it doesn't have to be the. Sorry.
I just get the $5 IKEA footstool.
Yeah, any footstool will do. It doesn't have to be the squatty potty. There are, I think there's some that are beautifully interior designer designed. There's the squatty potty one. There's people will just use the $2 shop, from the $2 shop. Just a couple of stools to put their feet on. So long as your knees are higher than your hips, I think you achieve generally what you're trying to do, which is to straighten it out. And like what Marika said, the unicorn poop video, actually whilst very, very funny, is actually factually correct. So it's a great way to educate, and it's got something like a gazillion, nearly 40 million views on YouTube. So it's sensational. What a great advertising campaign.
You know, anything with unicorns in, I'm sold. Like, clearly it's brilliant.
I think it'll be right up your alley, knowing you and your personality. It's fantastic and right up your alley. Marika.
Yeah, well done.
I'm a dad. I'm
gonna say dad jokes are no joke, is what I always say. So, you know, women are often given lots of advice from doctors, sometimes incorrectly, about, you know, what they should and shouldn't do. And often I've heard this a few times, and one of the questions that was put to us was they were told they shouldn't exercise or lift heavy weights if they have some type of pelvic floor dysfunction. And I want to know if you can sort of give some like ground rules about what they should or shouldn't do, and like how the body sort of works as that like piston type of system, if that's okay.
Sure. I'll deal with the piston thing right off the bat. The piston system thing is good. It's one way of having the whole system work together, and it's often a way that people have trouble doing. So what we notice around the body, this is in every joint, is that the piston thing is one of the things that people are missing. So we give it to them, they go, oh my God, it's so good. And they think that's the thing. The thing is that I've seen people with perfectly working pistons, but they don't know how to do any other way. And that way might be needed. So it seems like having all the ways is more important than having the correct way. As soon as you've got a correct way, you've got incorrect ways. And that leads to people being very narrow in their view on how they should do things. I was speaking to one of the local urogynecologists asking about weight restrictions and activity restrictions after surgery. And he specializes in cancer, like, you know, pelvic health cancers. And he was saying that there's no evidence to suggest a number. And so people are talking 5 pounds, 10 pounds, up to 35 pounds, but very rarely are they told the evidence for that. And basically, I think it's a culture of cover your ass, basically, because, you know, if something happens, people are going to point the finger. And so I think that ultra conservatism is about a very specific area, but it ignores. So I often say restricting activity on restricting activity in the hopes of saving a vagina is not holistic women's health, because you restrict her activity less than the recommended physical activity guidelines, you're increasing their risk of cancer, cardiovascular disease, stroke, diabetes. Like, we can literally increase the risk of somebody dying by telling them to stop exercising. And that's a massive problem, I think. And not only that, but the psychological impact of saying, stop the things that you enjoy. Like, suddenly people's identity may be brought into question because they identify as the person who loves going skiing. Every year for 40 years, we've gone to the snow. I'm going with my grandkids, and you're saying that I can't do that anymore. Like, that has a massive impact on people's lives. That is not healthy to do that. So I don't think it's incorrect advice. I think it's advice that's very narrow.
And generalized by the sounds of it, though, right? Yeah.
Yeah, and we don't know what goes on, right? We can assess people. I'm sure that Marika can tell stories too. We've assessed people that look like they're doing absolutely everything correctly, and then they go get injured, or they do something and something happens, right? You've cleared them for sport, and then they go have an accident. Like, it happens. That does happen. It's the fear that I don't like as a motivator. And I think that's part of it. I think also the advice that people give, we know, for example, people will say, don't do sit-ups or crunches. Cool. Well, then don't ever get on the floor to play with your kids. Don't ever get on the floor to play with your grandkids. Actually, don't ever get on the floor, because standing up and getting down onto a floor is more pressure on your pelvic floor than those activities. Don't ever sit down again, because standing up from a chair is more pressure on average, because it matters how you do it, than doing sit-ups, crunches, so many other things. Walking has more pressure on the pelvic floor on average than doing a Pilates class for most things, except rollbacks, right? Like, what are we doing to people? We're giving them advice saying, oh, don't raise the pressure too much, but I'm going to ignore the fact that you have allergies and it's allergy season. Like, why don't we just take care of the big issues like coughing, sneezing? Oh, you have an eating disorder, you have bulimia. Let's deal with that, because throwing up has the most intra-abdominal pressure that you can generate. You know, people with, sorry, I was just going to say, people with morning sickness will sit on the toilet with a bucket because they're throwing up and they're not controlling their bladder or bowel. You know, it's such high pressure activities.
Done that, bought the t-shirt. Yeah, you know. I remember once I got a stomach bug and I was puking everywhere and I was peeing myself and I was crying. I was like, why am I so shit myself as well? Because it's all coming out. All I was going to say is, like, the intra-abdominal pressure is something I hear a lot of from women who do like to lift. Like, they've found that that's changed through menopause. And again, I think that comes back down to that bearing down, to understanding the function and just checking if you've got, like, what function looks like for you. Because I don't want women to think that they can't ever lift again because they're peeing, and that's that old CrossFit sort of like narrative. It's not cool, and it's not okay. Is it? You should be able to lift, but you should be able to lift without leakage, right?
Yeah, and this is my passion topic. Yeah.
You just gave it a soapbox. But don't you think, sorry, on that though, Antony, like, we talk about people's like what they're happy to, because we don't tell people you shouldn't do that. Like, Antony and I are very big on your body, your choice, your autonomy. If you are happy to exercise and leak and it doesn't bother you, who the hell am I to tell you not to do it? Like, that is, I'll say, here's some options, but we are really big on giving people lots of alternatives and options and letting them decide. And I think that's really key. But in terms of what women are willing to cope with, a lot of women actually, if they have an occasional leak, will put up with that for the other benefits. What I find people have a really low threshold for pushing through is prolapse symptoms. So when people feel that lump or bulge, they're less likely, in my experience, and I'm interested to see what you say as well, Antony, to push through that, because there's a lot more of that sensation is like, oh shit, I'm going to have something come out of my vagina right now. And that's really scary. Whereas a lot of people, if they, you know, I mean, I've got a power lifter and, you know, she hits like 190, 200 kilos or whatever, and she leaks a few drops. Now, if she's competing in a massive championships, she's willing to put up with that. And we experiment, we try different things, but that's kind of her choice. And that seems to be more a sort of threshold issue there. But it's, you know, these are really interesting conversations, because it's always coming back to the person and what their experience is and what they're happy to put up with. And there's so much that we can do. And a lot of what Antony does is helping look at way people move, how they breathe. Is it what's going on in their head? Like, what are they thinking when they do that activity? Because for a lot of the time, if they've been leaking, they're like, oh, well, shit, I better brace everything. And then sometimes it's like, all right, can we just, like, let's have a play. And I love watching you work with patients, Antony, because you're really good at looking at what people are doing and trying to pick apart what they're thinking, and then messing with them, like doing something different, and then seeing what happens and finding ways to, because we ultimately, and I like, we're so passionate about keeping people moving and not putting all these limitations and strict rules and things, because it's all about their sort of quality of life and participation in life. That's so important. And then giving people the choice. And if they know the risks and they decide to push on regardless, then that is 100% their choice as well.
Yeah, absolutely. Thanks, Marika. Totally agree. And, you know, that autonomy is so important. And again, the way you do it, if you've been taught a bearing down strategy as your bracing strategy, I'm going to say simple because it seems simple to me. I've done it for a couple of decades of teaching people how to change it. But it is just a change in technique, not necessarily a loss of performance in the long term. In fact, changing the technique can lead to increased performance. I said at the start, I do performance enhancement. I do legal performance enhancement. And so, the way that you do it and the coaching cues that you're given may not be optimal for you. And that's really important. And with the prolapse things as well, I help lots and lots of people with prolapse by not just looking at them holistically, but seeing, okay, well, what are your symptoms? And because I'm external pelvic floor, I don't look, and I feel on the outside, I don't feel internally. And so people will often point to where they feel their symptoms. Now, if somebody can point to where they feel their symptoms, I'm not in the midline. Okay. So I'm not through the center. I'm outside the labia, in the groin crease, for want of a better word. How can I touch somebody's prolapse symptoms if I'm out there? I see a lot of overactive pelvic floor, which people then go, it feels like heaviness, it feels like pressure, it feels like this. They think they have a prolapse, and then somebody goes to look and they say, yes, you have a prolapse, because they can see movement on a test. And so then they equate that symptom with the prolapse. But if I, an external therapist, can put my finger on your prolapse symptoms, then is that the prolapse symptom? Do you see? Or is that a reaction to what you might be concerned about, or the diagnosis that you were given? Because I've had people have no more prolapse symptoms, and yet when they're checked internally, nothing has changed, yet they don't have the distressing prolapse symptoms anymore. Like, to me,
a lot. Well,
you do, yeah. I was going to say, can women, like, I don't understand prolapse, and I suppose I'm trying to learn more. Like, can women live with a prolapse and let it stay, or can it be reversed, or is it always surgery? Like, how can you explain that to me?
Antony's just muted. I like that. Yeah, so we have stages of prolapse. Okay. And I guess like a stage 1 prolapse is when the organs have dropped down enough but they're still within 1 centimeter of the vaginal entrance, is the simplest way. And then a stage 2 is from 1 centimeter inside to 1 centimeter outside. And then 3 and 4 is progressively worse. Now, when you get to the stage, like, we don't see a lot of stage 3 and 4 prolapses. Stage 3 and 4 prolapses, they're sitting outside of the body. Okay. They're outside of the muscular system. They will need some kind of intervention, and some will do okay with a pessary, and a lot will go on to have surgery. So I just want to mention that, because, some of them absolutely do need medical intervention, and some do brilliant, like many do brilliantly with surgery, and is absolutely the right decision for those women. Most of what I see would be a stage 1 and 2 prolapse, and that could be of one organ, or it could be of multiple organs. Now, what I guess we're changing a lot of this conversation now, because if we just think about what we see, if someone's completely asymptomatic, right? So I'll work a lot with new mums, and they come in, they're like, I want to go back to sport. Can you check? Pretty much everyone who's had a vaginal birth will have some movement, right? And actually there's been research where they've taken nulliparous women, so women who've never given birth, and then done testing, and half of them have a stage 1 or 2 prolapse, okay, on testing. And these are athletic women. I think these are paratroopers, for example. But in the general population, you're going to see it. And maybe this is a tissue quality thing. Maybe this is just normal. Like, how is everything supposed to stay exactly where it's supposed to be? We don't know this. And so what we have to do is look at what are their symptoms, and do they marry up with what we see objectively? And what will often happen, Amanda, is if the organs have dropped down enough that they're getting close to the entrance, that's when women will often feel the symptoms. So you can absolutely have an objective prolapse that's visible and have no symptoms whatsoever. And a lot of women, I have prolapse. Most of us who have had a vaginal birth will have some prolapse. Okay. I run, I jump, I swim, I cycle, I do martial arts it doesn't impact my life as long as I keep my bowels regular, I keep my pelvic floor strong, I keep physically active, and I look after myself. I don't have any symptoms. So a lot of women will have it there, but not have any issues. But it really does, like when it comes down to that entrance, that's when people tend to feel more symptoms. What I wanted to answer was your question about changing stages. Probably one of the difficulties is it's a very subjective examination, for one thing. And so what I might call a stage 2 prolapse, someone else might call a stage 1. It depends on what time of day, because if you assess someone at the end of the day, it's usually worse. Where they are on their cycle, if they're still having their period, if they're constipated, like all of these things can impact on what we see on that particular day. And then the other thing on that is, because I see a lot of postnatal women, we see that the recovery, of course, you get a huge change in the pelvic floor recovery in those first 6 months. So I'll have women come in and they're absolutely in floods of tears and they're so symptomatic. They're 6 weeks postnatal, they've had a forceps birth, everything just feels like they're coming out. And then we put in all the basics, get them having some relative rest during the day with their bum up, trying not to do lots of heavy exercise at the end of the day, get them doing their relaxation, meditation, looking after their mental health, taking away some of that fear about the prolapse, because as Antony said, when people feel like things are coming out, they're just terrified and they brace everything, sort the bowels out. And then if we need to, put a pessary in, for goodness sake. Like if things have dropped that low, that just walking around, they feel it, I would get a pessary put in. A lot of pelvic health physios in Australia will fit them. We're not allowed to fit them in the public system. We have to get the continence nurses and gynaes to fit them. But if you put something in to hold it up while they're in that recovery zone, the pelvic floor can actually, that gap between the two sides has more of a chance to recover. And yet some of those women will definitely change grade in that postnatal period.
That's super interesting. And I like the fact that you said that most of us probably have that and we don't know as well. Like, I definitely think it is subjective as well, because I think everything's so very unique and individualist, you know, in our health, that you can't just make these big assumptions. So
if I could, yeah. Amanda, I'm sorry. I just wanted to add to that I'm aware that getting a pessary, particularly in the UK, Europe, Canada, USA, basically everywhere but Australia, can actually be really, really difficult. And I just want to acknowledge that access is a problem. And it's something that we as a profession, like our physios, but also other health professionals and fitness professionals, we need to keep raising this awareness that access is an issue. And I just want to acknowledge just how privileged we are. I could, if I had somebody that I thought needed an emergency pessary for whatever example, I could beg one of my friends and they could just do it tomorrow or fit them in at some stage. Do you know what I mean? Like, it'll be this week that I could find somebody to fit them with a pessary. That is not the reality for most of the world. And then not only that, you come up with a patriarchal attitude of, oh, this is only for old women. You're not old yet. You're in your 40s, 50s, 60s. This is what I do for 80-year-olds. Therefore, I'm not going to do it. I am going to decide how to run your life and tell you what to do with your body. So I am going to decide I'm not going to give you a pessary because I don't think it's for your age group. Like, please, you know what I mean?
Well, yeah, we see it all the time, and someone's there saying truth, and it is true, and it's like a fight for everything in women's health. And I'm actually really happy that you acknowledged it as a man, because
all the time.
Yeah, thank you. So we're actually sort of coming towards the end of the time, and I wanted to know if there's anything we didn't touch on that you would like to talk about, and then I'll just take it to the group and see if there's anything we sort of like missed. It's been so helpful for me. I love speaking to you guys. I always get some like truth bombs, but anything that you think we would be beneficial?
There are two things. Number one, I think discussing some of the contributing factors to pelvic floor issues like incontinence, prolapse, and post-surgical considerations. I know that Marika and I have a passion about ensuring that these things are understood, particularly around the very I don't know if you allow swearing on these things.
Yes.
But the very shit BMI measure, but physics dictates that BMI is about weight, and it doesn't matter if you're super fit and lean, but heavy and muscular, or if you have high body fat percentage. It doesn't actually matter because it affects the pelvic floor. And diastasis, I think they're two things that I just wanted to quickly deal with. And there was, I'll do the diastasis one if you want to do the other one, Marika, just super quickly. So with the diastasis, I think there's a lot of talk about how it's related to back pain and pelvic floor issues like prolapse.
Can you just explain? I'm doing it. This is the hand one. Can you just explain what it is, please? Yeah.
So diastasis is where there is the six-pack muscles have a stretch wider. Marika is demonstrating. There's a gap between the two muscles, and quite often people terribly, I don't like it, call it like their mummy tummy or their pooch or their whatever name they want to give it. To me, it's just anatomy, but it's all the meaning around it that I don't like, really. If it empowers you, cool. If it makes you feel awful about yourself, I don't like it. And so if you have that, people are saying things like it increases your risk of pelvic floor issues. There's a 2007 study, which is a correlation study, which showed that a lot of people who showed up to a clinic with issues had a diastasis. Something like 2/3 had a diastasis. But what we don't see are all the women who have a diastasis and no problems at all. But not only that, why is having a diastasis a problem? And so for me, if you don't like the way that your tummy looks, if you're trying to pull your tummy in, for example, because you don't like the very disgusting, oh, how many weeks pregnant are you, right? How many months pregnant are you when you're, you've finished having kids, your eldest is 20 years old, like, that's just not very nice. And so having a diastasis like that, and then you changing your behavior because of how it looks for whatever reason, that is a strategy. That's something that you're doing, which may lead to pelvic floor issues because you're increasing the pressure and you're concerned about it. As opposed to, oh, it's the fascia, because of fascia, it's not supporting your pelvic floor and your organs. And it's like, anatomically, I cannot find any support for that apart from people saying it. So to me, it's the behavioral aspect around diastasis and your beliefs about it. If I tell you that diastasis will give you back pain and you've got back pain, you're likely going to increase your tension. And we know from the research that people with back pain have increased activity in their core, and then we tell them that they have a weak core or they're not using their core. Like, how does that work, right? People without back pain have lower usage of their core muscles because pain makes you contract. It's painful. So all of those things increase your pressure as well. We can measure it on sensors. As soon as you go to move anything, we know the pressure rises. So how you do it matters more than what you do. And that's a summary of what I have on diastasis. I'm putting together a whole bunch of hopefully high quality information that's available by donation only, so that people don't have finances as a barrier to good quality information, and no fear-based marketing. It's just, you donate what you think it's worth. And we just want to have good stuff out there because, anyway, I could go on for a long time about women's health and what we do to get good quality information.
Before we go over to Marika to speak about the BMI stuff, I will share all of your resources with the group because I know it's super helpful stuff. So, but thank you for making it accessible, Antony.
Oh yeah, no, of course. It's definitely a passion project. It's not one that my accountant wife likes because you don't get paid for it. But I think it's important, right? I think it's really, really important to change the narrative, to change the space of possibilities out there.
And I'm glad you're doing it because I'm so sick of talking about diastasis. Antony laughs at me because I'm like, oh God, if I just see one more thing about diastasis and people freaking out over it, it does my head in, because I work so much with new mums, and, 99% of the time, if we just give them a good structured exercise program that progressively loads the abdominal wall, they do great. Like, they really do. And it's just, you talk about fear-based marketing and stuff, and I have women coming in floods of tears with a 1-finger gap, and I'll say, this is completely normal, like, and you're really strong and you're functional. Get on with life. We don't need to worry about this. After our abdominal wall is stretched to go through pregnancy, we shouldn't expect it to come back to literally sitting side by side. And there was one day, Amanda, I know we're going over, sorry, where I was teaching to a whole bunch of sports physios, and we were practicing measuring diastasis, and 4 of the guys in the room had a 3-finger gap, right? And these were very muscular, strong guys. Is that abnormal? Is that dysfunction? Should they run out and have surgery?
Well, they probably wouldn't get pulled up for it. That's the ironic thing about that. I went to a pelvic health physio for my issues, and she said, we said diastasis rectus. I suppose it's the same thing, right?
Yeah, it's the same thing. Yeah.
And she said, you have a 1 centimeter, and I was horrified, and actually was like, but I'm like really strong. It just didn't make sense to me, and it doesn't bother me. And then I was a bit pissed off. So, yes, I agree. Okay, let's
Whereas I say, you've got a 1 centimeter gap. That's brilliant.
Yeah. Okay, so let's go on to the last topic, and then we can...
Oh, you just muted yourself. All right, so it was about BMI, right? Yeah, so Antony...
Sorry, yes, I did. I'm not very good.
Antony pretty much commented on it, but
contributors to pelvic floor dysfunction, including BMI. Yes.
So there are things that we do have evidence for, which will increase people's risk of having incontinence and prolapse, and an elevated BMI is one of them. And so we actually have really good evidence for this. And it's always a tricky conversation to have with people, but people need to know. So we will see some women, and again, I saw someone the other day who was 120 kilograms. She actually did have a lap band operation, and she lost weight, and her symptoms improved just progressively as the weight came down when nothing else changed. And maybe that again was that she became a little bit more physically active, but it's a pressure thing. Like Antony talked about, it's that, that weight just sitting on the bladder, you're fighting so hard to maintain that urethral closing pressure against that extra pressure from above. So, it's always worth having that conversation. And again, we don't really put pressure on women to lose weight, but we have to also educate women and say, these are all the potential contributing factors. And a high BMI is one of them, in conjunction with, we talked about the chronic constipation. Smoking is one as well. And obviously the more babies you have, the more vaginal births. If you have forceps is a really big one. And I think in Australia, we're seeing a lot less forceps births, because they do cause, for some women, trauma to the deeper layers of the pelvic floor, which changes the structural support of the organs and can make women more susceptible to having things like pelvic organ prolapse. So, there's lots of things that we can look at and talk about, but they're some of the main risk factors. And aging and menopause. Hormonal changes associated with perimenopause. Yeah.
I think we've all worked that one out, though, in this group. We all realize that it's our bloody hormones, but that's super interesting as well, super helpful. And, I think that the weight conversation, you guys are clearly very respectful, and unfortunately that isn't always what happens, though, right? Women have really bad experiences when it comes to BMI and the conversation, and weight is very much stigmatized over here as 100%. Well. Yes,
everywhere.
Everywhere.
And I'm 45 years old, so if I go into a gym and start to talk to a PT, I get given the weight loss package, and it's like, well, no, actually, why do you assume that is my number one goal of exercise? And so there's so many assumptions that made, and we just need to talk to people and ask them, their questions, ask them their aims. What are their goals? What do they want to achieve?
Yeah, anyway. Exactly. Yeah. And I agree. And also the assumption that it isn't always because of weight as well, right? You can be perfectly healthy and have weight on you. It's anyway, so I loved everything about today. It was so informative. One of the big takeaways I took from this that I didn't truly understand was the sort of the neurological response and how important that is to the pelvic floor function. And so how we even think, how we like that, how we even approach the whole thing from a mindset point of view. I never would have put that together in this conversation. And so I love that. And I'm keen to learn more about it. But the idea that women try and take the fear away, I kept thinking of a dog. I know that's terrible, but you know, like a dog, when he's scared, what does he do? He tucks his tail under. And I suppose it's that reaction, right?
Yeah, absolutely. And you know, also getting outside, like women, it's so stupid, can I tell you, that I, as a man, are telling female therapists not to be matriarchal, I suppose, but like, why am I telling people who are feminists not to tell women what to do with their bodies and their choices? That's very, very frustrating for me. It makes it difficult as well, because I have to be careful in how I do that, because you don't know what you don't know. It's why I have people like Marika as friends, because she will call me when I'm doing bullshit things. Do you know what I mean? Like, she'll just tell me. And it's like, dude, you are off base. And it's like, oh, I didn't even realize, right? So I think it's so important to not just focus on the pelvic floor, but recognize that women are people, and meaningful activity, so important. Find the things that you like to do. Find the things that give you relaxation. Find the activities and the people to do it with that you love. And so there are so many people that find things like CrossFit, and then they're told that CrossFit is bad for them. Well, how you do CrossFit might not be helpful for you, but you know what? That community of people might be exactly the thing that got you through this tough time in menopause. And I know that this has happened for a lot of women, where they love their 9:30 crew because, you know, everybody's gotten together and they're so supportive. And of course, you can have a terrible experience there. And it doesn't have to be CrossFit. It could be whatever it is that you do with other people, a book club, you know, a walking group, a yoga class, a Pilates class. It doesn't really matter. If you love it, I want to support you doing it, because you're much more likely to stick at it. And we know that consistency is so important for health. We know the physical activity guidelines are there, and the physical activity guidelines are the minimum. Apparently, you can do 2 to 4 times the guidelines and you'll maximize the benefits of physical activity, right?
That's
and
awesome.
So
and actually, on the flip side of that, I love that you said that. A lot of women stop themselves doing those things because they have pelvic floor issues. It limits their scope, and so it's come full circle, right? So looking at not just pelvic health as an isolated thing, but looking at it as a holistic, like whole body, mind, soul, how we approach it. I just wish
what if that solution is to find a class that you love, that you're happy with, that you have great support in, and that's the break in the circuit that allows you to change your symptoms, right? Why don't we talk about that enough?
Well, actually, that could be for everything, couldn't it? That could be for every symptom we have, actually. Yeah. I love that. I think that's probably a really great place to end. I'd just like you both to take a minute each to say thank you, where to find, I'm going to say thank you to you, sorry, where we can find you. And obviously I'll make sure people have that after the show is over.
Oh, sure. I am based in Perth in Western Australia. If you want to get in touch with me, if you're local, Marika at dynamicstrengthphysio.com.au. I don't do a lot of telehealth at the moment just because I'm just way too busy. But feel free to reach out. And I do a lot of work with Girls Gone Strong. I help them create their certifications for fitness professionals. So helping the pre and postnatal population and women in general, coaching and training women. So we do have a really good network of trainers who are really, I think, Amanda, you know, the stuff that we teach is very much on board with your philosophy as well at Girls Gone Strong. So, you know, I'm more than happy for people to reach out to me, and I can try and put them in touch with people who have trained through those courses as well. But yeah, I want to just say a massive thank you for having us on here. It's always a pleasure to talk to you. It's really good fun. I like that it's relaxed and I can swear occasionally, because Antony is, he's like the good cop, and I'm the bad cop who likes a bit of alcohol and swearing. So he's the yin to my yang.
That's why it works so well.
But it's been really fun, and I love the work that you're doing to cut through all the bullshit and really support women through what could be a really challenging time for many women. And I love that you acknowledge that this is something that can be shit, and but there is a lot that can be done to help support women, and we really want to improve access. We want to improve the networks that are out there, and women to get that full multidisciplinary care. And one thing we didn't talk about, which I do a lot in public health, is we use the psychologists a lot. So the clinical psychologists are really important in that role as well. But yes, thank you. That's me.
Thank you, Marika.
Thank you. And yes, for me, you can find me on all my social media at the Physio Detective, at Physio Detective. So Physio Detective. I also run education courses for health and fitness professionals, as well as for the public. So if you're interested in anything like that, you know, Physio Detective, mypteducation.com is where you'll find that stuff. But otherwise, contact me. If you shoot me a message, I'll reply. I'm not one of these, you know, aloof type people that you need to qualify to speak to me type. That just goes against the grain of what Marika and I are about. So please contact us. Let us know what you're going through. We've got contacts around the world that we can help direct you if you're having trouble finding someone to support you. And you know, there's lots of different options that we love helping people with. And of course, our podcast, the Women's Health Podcast, for anyone who identifies as a woman. It's okay. That's why we work well together, because you pick up the stuff I forget.
My Instagram is Marika, at Marika.
Marika.Hart. Marika.physio?
Marika.physio is my Instagram.
Yeah.
Although I'm nowhere near as good as you two.
I will make sure everybody gets everything. So yeah, nobody's on it as much as me, unfortunately. It's my sad life. But thank you, guys. Thank you so much. Take care, everyone that joined in. I very much appreciate this.
Yeah, no, thank you. And thank you again for having us, Amanda. Fantastic. And I'm sure both of us would be happy to speak to your group again if that's what they would love.
That's great. Thank you. Bye-bye.
Bye.